From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello, and welcome to our listeners around the world. You're listening to JAMA Dermatology Author Interviews. Thanks for joining us. I'm Dr. Adamson, the web editor for JAMA Dermatology and the host of this podcast episode. Plaque psoriasis is increasingly managed using anti-inflammatory biologic medications, including tumor necrosis factor, or TNF-alpha, and interleukin 12, 23, interleukin 17, and interleukin 23 inhibitors. How these differentially priced biologics are used has implications for the overall cost of care in the United States. In a new study in JAMA Dermatology, authors measure trends in the use of first-line biologic treatments and examine the impact of cost of care from 2007 to 2021. Dr. Benjamin Rome is a physician and researcher in the Division of Pharmacoepidemiology and Pharmacoeconomics at the Brigham and Women's Hospital. He's also an assistant professor of medicine at Harvard Medical School in Boston, Massachusetts. He's here to discuss this work. Welcome to the podcast, Dr. Rome.
Thanks so much for having me.
So I'm excited to have you here on the podcast to talk about something that is important to a lot of doctors as well as patients: cost, especially for these biologic medications that we're using increasingly to successfully treat plaque psoriasis. But before we start, our audience may not be as familiar with you. You're not a dermatologist. You're a primary care doc in Boston. So tell us a little bit about your breakdown in terms of practice, how much % time you dedicate to research, what type of research that you do.
As you mentioned, I'm a primary care doctor at Brigham and Women's Hospital. So I see patients about 25% of the time and then do research and teaching for the rest of my time. I work in a group called the Program on Regulation, Therapeutics, and Law, or PORTAL. We are an academic group that studies kind of the intersection between prescription drug regulation and cost and use, and really focusing on evidence and making sure that people are using the right medicines and that people are able to afford those medicines. That's kind of the main thrust of what I do. So I end up studying prescription drug prices quite a bit, and that includes drugs in a variety of different fields. And in this case, plaque psoriasis is a really interesting example of some of the trends that we've been seeing over the last several years.
So you mentioned that you study a variety of different diseases and disorders, or maybe you're somewhat agnostic to what disease entities are at play here. What kind of drew you and your team to want to study biologics in psoriasis?
We were drawn to study this particular disease area and this sort of set of drugs because there's increasingly a lot of options for patients with plaque psoriasis, a lot of really expensive biologic treatment options. Many people, even if you aren't familiar with the specific drugs, might have seen ads for these on TV. These drugs are increasingly used by patients and by dermatologists in the US and around the world to treat this disease. And the fact that there's so many treatments, the fact that there's a variety of different types of treatments means that there are choices to be made about which drug patients and doctors are going to choose. And that can lead to situations where people might not be choosing the most cost-effective treatment, right? They might be picking a medicine that costs a fair amount more than other treatment options, despite offering marginal benefit to the patient. And so I think that tension, and we sort of have been looking at this class of drugs for several years, has led us to use this as a really good case study. The other piece is that some of the biologic drugs that are used to treat plaque psoriasis are at the end of their life cycle and now actually have competition, biosimilar competition, which drives down the price. And so that's another interesting factor here that led us to look specifically in this disease area.
That is true. I mean, biologics have been around for close to 2 decades now, and there's clearly over a dozen different biologic medicines to treat plaque psoriasis. And some of them have been so effective that they can basically clear patients. As many in the audience know, that comes also at a steep cost. So the goal of your study was to look at the trends and the uses of these various biologics. Can you explain, one, what database did you go to try to look at trends in cost? Did you look at just trends in cost in the commercial space? There's also Medicare where this can be an issue. How did you go about choosing a database to study? And could you describe that database and what were you looking for?
In terms of measuring the use of the drugs over time, we used a national commercial claims database. So it reflects kind of a broad group of patients who have commercial insurance. It doesn't include those with Medicaid and Medicare, who obviously also get treated for psoriasis. We think the majority of patients with plaque psoriasis have commercial insurance, and about half of all Americans have commercial private health insurance anyway. So it's still a very important question. In terms of the prices of these drugs, we use several different data sets to nail down the prices for these drugs over time. We start with the manufacturer kind of list price, the price that they charge for the drug or that they put out there and say, this is what we think the drug should cost. And then we account for what are rebates or discounts that are given on these drugs, often confidentially to insurance companies and pharmacy benefit managers. And so we used a data set called SSR Health that estimates what those rebates and discounts are for these drugs over time. None of this is perfect or exact. The prices of different drugs, because they're being negotiated by individual insurance companies and payers, can vary. But I think this gives us a good sense of the general trends over time that can be informative for everyone who's in the space of policy or clinical dermatology to sort of best understand what's happening.
For the study, were you looking at just all prescriptions for biologics, or were you looking at specific types of prescriptions, like new prescriptions versus refills, et cetera?
Yeah, we were specifically looking at a cohort of patients who newly initiated a biologic drug for plaque psoriasis and that they hadn't previously used any other of the biologic drugs in our study. And the reason for that is we wanted to really focus on that choice of first-line treatment because that's where there's probably the biggest potential policy impact in terms of choice of treatments, right? So once a patient has tried and failed one or two or more treatments, obviously the cost is important, but you sort of have to open up other therapeutic options. But when you're having the conversation between a doctor and a patient for that first line treatment, right, often it can be successful. So the choice of medicine they make could have long-term implications in terms of the cost of treatment over time.
And going into this study, before you saw the data and the results, what did you think the curves were going to look like for the various different biologics? Because you grouped them in terms of mechanism of action. You also grouped them by medication. You had several different angles in which you analyzed the data. What were some things that you thought going in you would find over the 15 or so year period of this study in terms of general trends?
One unfortunate truth in healthcare is that prices and costs tend to go up over time. So we did expect that the prices of these treatments would increase over time based on other research we've done on drugs in this area. One of the other reasons we were particularly interested in this area is that the initial biologics that have been used to treat plaque psoriasis included TNF-alpha inhibitors like Humira or Remicade, so that's adalimumab or infliximab. And increasingly, there have been a number of sort of newer classes of medicines like IL-17 and IL-23 inhibitors. So we were really interested in figuring out how much use of those newer treatments has kind of overtaken some of the use of the original biologics used to treat this disease. So I didn't necessarily have a prediction, but that was one thing I was really looking for.
And did you find it?
Yeah, absolutely. The average price for 1 year of treatment of a patient who was starting on one of these first line treatments more than doubled from 2007 to 2021. So from about $21,000 up to $47,000 in
Wow.
2021. So that's a huge increase in price. And that was driven by obviously a bunch of different factors. Sometimes it's the prices for individual drugs going up, but it's also driven by an increasing use of some of the more expensive, newer classes of medicines, and particularly certain medicines that are sort of above average in terms of their price compared to all the other options. One of the other things is that the prices in 2021 are variable, right? So they range from sort of like $10,000 a year up to like $70,000 per year. Back in 2007, the prices were all clumped together and much more tight. So maybe the choice of medicine was less important in terms of the impact on cost for patients in the healthcare system. Now, I think that choice really does have important implications. And some of that is biosimilar competition, sort of driving down some of the prices for the older medicines like infliximab. Some of that is just the more drugs you have, right, the more variability you're going to see in the prices for those treatments. So I think the increasing price, average price, but also the increasing variability in price are really important and have consequences for how we think about incorporating these data into clinical practice and into policy decisions, both at the sort of national, state level, but also policies by certain payers and insurance companies that are making coverage decisions about which of these treatments to cover or to steer patients towards when they're sort of newly initiating treatment for psoriasis.
So you didn't have any patient outcome data related to your findings?
No, in a previous paper, we looked at the variations in the effectiveness versus the cost of these treatments at sort of a single point in time. There is pretty good data to suggest that some of the newer classes of medicines, like the IL-17 and IL-23 inhibitors, are likely more effective than some of the older medicines, like the TNF alpha inhibitors. So we weren't sort of really questioning that. And I think that's obviously a hugely important consideration when choosing a treatment, right? Patients want medicines that work, and they don't want to take medicines that don't work and that might have side effects. So you're totally right that this study didn't include that effectiveness component of it. This is really just focused on the downstream consequences between price and effectiveness and all the other factors that patients and doctors are thinking about. What are ultimately patients using? And that's, I think, where this study adds important information.
And did you look to see use of biosimilars over time as well? And did you note in your study whether that was going up? You mentioned that the introduction of biosimilars can drive down some costs related to biologics. So did you find that there was an increase over time?
We did include the biosimilar medicines for infliximab in this study. This study only went through 2021, and so it didn't include the biosimilars for adalimumab or Humira, which came out in 2023, and also for Stelara or ustekinumab. Those biosimilars came out actually just earlier this year. And so there's been even more changes even since the end of this study that could affect the variation in prices and could potentially drive down the prices for some medicines. So we didn't look specifically at Humira in this study, but in other studies, we have found that competition did lead to lower net prices for the healthcare system. We are spending less on Humira and its biosimilars now that there is competition for a variety of different reasons. And I expect we'll see the same for Stelara as well. But I think that actually heightens the reason and the importance of this study, which is that as those older treatments become less expensive for patients and for the healthcare system, it really raises the question of how much more should we be spending for these other newer treatments like the IL-23 and IL-17 inhibitors. So for example, risankizumab or Skyrizi in our study was the most expensive treatment, north of $70,000 per year to treat a patient with psoriasis. And that is a very, very high price tag when there are a lot of other treatment options within the drug classes that are less expensive, especially when there's other drug classes that are much less expensive because they have competition. So I think that it's really important to understand these data and to sort of continue to understand how this evolves over the next few years as more biosimilars come to the market.
So what I'm hearing is that this is a study that tells us where we've been and where we are now. And it is a benchmark for how we kind of look forward to this really rapidly changing marketplace of biologics, biosimilars. What other aspects do you think could add even more to the study? Perhaps some cost effectiveness analysis, right? Because if you think about the TNF alpha inhibitors and maybe adalimumab or Humira as an example, they may not be as effective as some of these newer IL-17 inhibitors. So how different should that pricing be to get that extra clearance? Do you think that that's an important question to ask or investigate in the future?
It's absolutely important to balance the cost and effectiveness and safety and everything in terms of making those treatment decisions. And I should be clear, there's cost to patients, how much the patients are paying to access treatments. That's hugely important. We know that high cost to patients prevents them from filling medicines, and often they won't take or adhere to medicines if they owe too much of the cost. There's also just cost to the healthcare system more generally, which we all pay for premiums and taxes for both private and government insurance programs. So both are really important. Obviously, the individual doctor and patient are usually much more attuned to thinking about safety and effectiveness and having that conversation than they are about cost. But I do think that has to change at some point, right? You have to at least understand cost as part of the equation, even if it's not going to be the primary factor. Certainly, payers or insurance companies are thinking a lot about cost, and that can often lead to sort of tension between doctors and insurance companies, right? If the doctor and the patient want to choose one option and the insurance company has negotiated a really good rebate for a different treatment option. And so I think this already affects treatment decisions, whether we like it or not. I think we just have to have a better understanding of how it affects treatment options. And in terms of your point about cost effectiveness, it's really important. A lot of countries use cost effectiveness analysis to help determine coverage and prices of treatments when they come on the market. But it is a little bit of a moving target, right? Particularly if the older treatments are going to face competition and the prices for those treatments come down. If that happens, then obviously that changes the equation somewhat for the newer treatments, which nothing has changed about the differential safety and effectiveness of the treatments, but the price tags have changed.
So, Dr. Rome, what do you think a dermatologist in 2025 should be thinking about the current trends or the trends in the near future or the trends post 2021 related to biologics and plaque psoriasis and cost?
As the landscape changes, as some of these older treatments have competition and the prices are falling, and as there's increasing evidence about the newer treatments and differential benefits for patients between them, this is going to be a really important tension for dermatologists and other specialists who use these types of anti-inflammatory biologic drugs over the next few years. I think dermatologists are going to feel this, right? They're going to feel pressure from insurance companies to use more biosimilar treatments. They're going to have to explain to patients and help patients understand these differences. How big are the differences between the effectiveness and the safety of the different treatment options? And, ultimately, they're going to have to justify some of their treatment decisions to payers. You can understand why an insurance company who sees a prescription for a $70,000 drug would ask why, that is necessary over a $10,000 per year treatment. And so I think that dermatologists have to understand what the lay of the land here is, which treatments are going to have biosimilar competition, which ones are not, recognize that prices vary greatly between these different treatment options, and really think critically about what the right treatment approach is, sort of what's the first line treatment for psoriasis, and should patients be trying some of the older, less expensive treatments before they move on to try the newer, more expensive treatment options, which patients are best targeted by different treatment options. So I think it's really important that dermatologists and other specialists understand the space. I hope that by putting this paper out there, we provide some more data to sort of make this more concrete for clinicians and policymakers to understand this and make informed evidence-based treatment decisions.
I want to thank you so much, Ben, for being on the podcast. I am Dr. Adamson, and I've been speaking with Dr. Benjamin Rome about trends in the use and cost of first-line biologics to treat plaque psoriasis in the United States between 2007 and 2021. You can find a link to the paper in this episode's description. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening. Catch you on the next episode of the JAMA Dermatology Podcast.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.